My name's Jeff Capobianco. I'm actually from Michigan, but I work with the National Council quite a bit. Also work with the University of Michigan School of Social Work. And my background is in working in behavioral health. And when you hear me talking about behavioral health, it's the health reform language that includes substance abuse and mental health treatment. So my background is in that. Over 20 years now, started working in group homes, case management, outpatient therapist, graduated to wearing a tie, did quality improvements, went back to school, kind of done it all, a lot like you folks here. But I want to find out a little bit more about who I'm working with here in the room so that I can better gauge my presentation to who we've got here. So how many people work primarily in substance abuse? So you got most of the room, I'd say 80%. And then how many people are primarily administrators? We just got, what, 4 or 5 people who are administrators out of close to 40 people here? Anybody who's just working in the mental health arena?
I work with co-occurring.
Co-occurring, okay.
Regional supervisor.
Regional supervisor, got one person to that. Any sponsors, peers, consumers of services? No, nobody. Okay, great. So what we're going to do today is going to be a crash course in what we're calling moving from case management to care management. Case management is horrible terminology, but for some reason we just can't seem to lose it in our field. So it would be nice if we could at least move on to care management. It's a tall order in that we've got about 3 hours with a break. So what I really would request of you all is to ask questions as we go along so that I can target the presentation to what you showed up here to hear. And if you didn't know what you showed up here to hear, then as things emerge in your mind, please raise your hand and we'll get into a discussion with it. There's a lot of slides, a lot of handouts. I'll probably move a little quickly through some of the slides that have a lot of information. The reason for that is the approach we're taking with this training is we don't want to get to the point where we're trying to train people in primary care. That's not the goal. The goal are these 3, 4 things with our presentation. We're going to look at the Affordable Care Act, answer questions around that and how it's influencing your careers, really, if you think about it. It's going to influence your job quite a bit over the next 5, 10 years. We're going to talk about the differences between primary care and behavioral health and how some of those differences make it easy to work together and how some of those differences make it quite interesting in how we work together and what that's all going to mean for you moving forward as you have to develop relationships with primary care. We're going to talk about developing physical health goals, disease management, diet, and exercise. How many people have had pretty good training in motivational interviewing? A lot of people, so 3/4, I'd say, of you folks. So we're going to touch on that. Might not dig into it as much as I would if we didn't have a lot of training on that already. And then we're going to end the day, or the morning I should say, with a survey of the signs and symptoms and treatment approaches for diabetes and vascular disease. The reason for that is those are the 2 biggest killers of most people in the world, actually, but certainly the populations we work with. There's a lot of other issues people have around health, physical health conditions that need addressing. We're going to focus on those 2, and the approach is going to be not to kind of, again, make you guys LPNs or RNs or doctors and have to learn all the ins and outs of what diabetes is and isn't, but to give you just general information that you can take back and use when you're working directly with people who are receiving services. So the approach is going to be what are some basic information that you can share while you're working with people in your clinical practice. Because again, the goal isn't to make you guys primary care providers. You got plenty on your plate. We realize that. The idea is to just give you some broad information around how to engage people around physical health, because it is a really big part of recovery, and we as a field, in the behavioral health field, just haven't done it as well as we maybe could, and certainly primary care hasn't done as well as they could helping people with mental health and substance abuse. So this health reform has really put us in a position where we can do a little bit better and maybe even make our work a little bit more efficient and effective and rewarding as clinicians and administrators. So again, tall order. We've got the morning to do it. I think we can get there. Any questions on the presentation outline? Make sense? I talk quickly. Part of the reason is because we get just a couple hours to cover a lot of cool stuff. But again, don't let that prevent you from asking questions. So if we group all of you into this world of case management, whether you're an administrator, an outpatient therapist, or a case manager, or whatever you're going to call yourselves, you're working in an environment that is quite daunting, actually. You're doing a job that most people in society don't really even know about or recognize, but it's very, very important. And as we know, it's pretty much underfunded, and you've got a lot of work on your plate to support the people that you do. Every couple of years, it seems, there's something that comes along that says, hey guys, hey clinicians, administrators, mental health policy folks, we want you to do something new and exciting. We have a new evidence-based practice for you, right? There's always something new coming along. And now we're in the middle of health reform. So with that as the context, we understand that you guys have very large caseload sizes. You've got barriers to being able to deliver services to folks that include things as distant as transportation, just getting people to appointments, very practical stuff, all the way down to complex clinical issues around why people are having a difficulty understanding why they need to change to reach the goals that they want to reach in their lives. So there's a lot of barriers to the work you're doing, and physical health issues are definitely impacting the people you work with. We don't have time to get into a bit discussion based on your experience of what that looks like, but would most of you agree that the people that you serve have physical health conditions that are either being addressed or need to be addressed? Yes. So it's stuff that you're seeing out there, and I would assume that most of us would agree that it's a really big part of recovery. So if you're going to recover from substance use and addiction, mental illness, you've also got to have your physical health in a position where those things are going to be able to line up and you can fully recover and do the things that our good friend Freud used to say, to be able to work, love, and have fun. Those three things, I mean, those are the big things in life. So if you've got recovery, it includes mental health, substance use, and physical health, big part of that. So I'll throw this out to the group, any ideas of what's going to happen with health reform? People think it's kind of just going to go away? You think it's here to stay? You think this really is a big deal? Or is it a passing fad?
It's been going on for a while.
It's been going on for a while?
Yeah, we were in health reform in 1989.
Yep, we were in health reform in 1989. You're right. So there is this feeling that, okay, here we go again. And it's this cartoon here that says, we're ready to begin the next phase of keeping things exactly the way they are. So this is really the contrast. Are we going to have this cartoon approach, or is it going to be this, this incredible thing with clinicians building bridges that include all these crazy concepts like comparative effectiveness and accountable care organizations? Is something really going on that is going to be different? I think it's safe to say yes to both. I think there are going to be things that aren't going to change much. People are people. They're still going to be struggling with the conditions that they have. We're still going to find people like yourselves that get up every day and have a passion to do what you do. But I do think what is going to change, which is going to really impact your job specifically, is the funding mechanisms. Because funding always changes practice in different ways. So we are going to see changes to that. And depending on the state and depending on where in a state you work, there could be significant changes to your jobs, which we'll talk a little bit more about. So any questions on that piece? The current reality that we're dealing with is behavioral health budgets are continuing to be cut, and with health reform, there's talk, if you listen closely to the politicians, that they're seeing health reform as a way to really save money. But when we're talking about the people we work with who have multiple chronic conditions, there's not a lot of money to be saved there. It's actually cheaper to let them die young, like they are, than to help them live longer. You could create some efficiencies around helping them with prevention and maybe not having extreme disease processes going on that are expensive. But bottom line is the system's pretty tapped out when it comes to money, and people think that there's actually more money to be gained from working with you all around consolidating the health system through health reform. So that's kind of a scary notion. As I mentioned, health reform, it really is going to impact your job directly. We'll talk a little bit about that. Integration, have you heard this word enough? Integrated health, health homes. What are the other catchwords that are going around? Person-centered care. What's that?
Holistic treatment.
Holistic treatment, whole health approaches. That's all the lingo right now in the policy world. And it is the future, just because primarily the United States can't afford to be spending over $1 trillion a year on healthcare and see it going up by 10% every year. It just can't. So something has to change, and that's why we've got this healthcare going on. Patient-centered health homes are the future. That is the primary language that's being used, which I'll talk more about in a little bit. And we know that people with mental health and substance abuse disorders are dying at younger ages than the general public. We're going to talk a little bit more about that. That's the context we're in. We're also in this context where our health system in general is one where we treat people when they become really sick. And we're all part of that. We've all experienced that ourselves. If you get sick, it's pretty tough to, get into the doctor, to get the whatever medication you can, to get to the pharmacy, to get it paid for, all of that. It's quite a process to get health care. So what ends up driving that is you've got people that are receiving services from 3 or more physicians because they have to go around to get care. There's a lot of specialty care. You've got Americans that are getting sicker and sicker, but they're having difficulty getting into the system because the system really is designed to treat acute conditions. And it pays for that. So you get more money as a provider if someone shows up and needs a very specific thing that's usually at an acute stage of an illness than you do if you do prevention. Prevention wasn't paid for prior to the Affordable Care Act. It's paid for now. But we've had this system that's really designed around acute care, which is driving up costs and creating problems for people to be able to access care. That's probably not a shock to you all to know that. Yes?
But doesn't prevention preventative health care is designed to save from debilitating illnesses that may occur in the future, like HIV, HIV, other illnesses that hepatitis C,
Right.
that require prescriptions and constant visits to a doctor, maybe specializing in that kind of care. So
I don't
isn't
disagree.
Oh.
See, her point is that, well, prevention should save us money and maybe even certainly make people's quality of life better, but maybe even make the health system a little more efficient.
Yes.
I don't disagree with that at all. My point around cost savings is you're not going to create a huge surplus of money as a result of adding prevention services across the board. You might save some money if people live longer, but they're not as sick through their lifespan, because a lot of the money that's spent on people is right before they die. The last 6 months of life are the most expensive, and if you keep people healthy longer, they'll have a more natural death process that might not cost as much.
Right.
But the concern when we talk about health reform and money is that there is this talk that, hey, we're going to save money, especially with the sickest of the sick, which is a group you all work with. And those folks are going to remain sick. Prevention will certainly help, and they can get better. But there's not a lot of money to be saved with our folks. That's why nobody traditionally has wanted to work with our folks. Now Medicaid is seen as a place to go as a hospital system or a physician group if those continue to exist. They want to start seeing Medicaid people because those folks have the funding. So it's an interesting dynamic that's occurring, but you're absolutely right. Prevention helps with quality of life and can bring about some cost savings. Whether it's enough to save our system, we're going to have to see. I think at the end of the day, what's going to end up, and this is my soapbox on cost, saving money for the system is going to be paying providers less. So Atu Gawande's work in McClellan, Texas, where he showed that he went to the most expensive place in the country as far as getting health care because they billed the most to Medicaid, Medicare, and found that the business model in that region had just been set up to where they could really bill quite a bit for services. It wasn't anything malicious going on. They had just set up a really nice system where they did a lot of procedures and they got a lot of billing for that. So that ability to, as a provider, make a lot of money off procedures is going to be tapped down a bit with this whole idea of bundled care and looking at quality and prevention and other factors other than just providing one specific care. And people are going to be held accountable. That's why they call them accountable care organizations. Clinicians are going to be held accountable for making sure that people are healthy, as opposed to just putting out an acute illness, a fire, dealing with things in a very episodic way. So it's going to be interesting. It's going to take years, but it's going to be interesting to see how this pans out. The whole idea of chronic care management and health reform in many ways can be tied back to Ed Wagner's model called the chronic care model, which I'll move through really quickly. But he did a study back in the 90s, late 90s, where he wanted to know why are people not functioning well and getting good clinical outcomes who have chronic health conditions. So he backed into the health system and took a look around and found things that we're all aware of, but he did it with NIH funding, and it's evidence-based and randomized control, so it really helped the policymakers say, hey, this is really an issue. We've studied it really closely, and it's not just anecdotal evidence we're hearing from health experts. This is real. The problems he uncovered were clinical health information systems weren't very good at sharing information and providing clinicians with the information they needed. Most of them at the time of the study were paper-based. We're up to about 20% of providers having electronic health records. But if you're anybody that's implementing a health record or has just implemented electronic health record, they're not quite super helpful yet to us, I don't think. There's a lot of clicks to get to what you want to get to. That will get better over time, I think. But one of the things he identified was, the clinical information systems weren't very good, and clinicians didn't use them as a way to share information very well. I think that's going to get better. He also found that decision support, particularly within primary care, was really centered on the physician needing to make decisions, because physicians were moving 8 to 15-minute appointments. They didn't have time to check in with the nurses or the front desk staff or behavioral health folks like yourself to kind of get a better picture of what might be going on with the person, or looking at pre-existing issues that the person might have that the other staff know about that would help inform how to make a clinical decision to help that person. He found that decision support was really stuck with the physician. And the physicians didn't necessarily like that. They want a team to be able to work with them around helping people, but there was no time for them to have that. Also found that the delivery system design, as we just mentioned, was very focused on procedures and acute care. So people needed to get pretty sick to get into the system, and when they did get into the system, they needed to do their own case management. They needed to navigate through the system on their own, which if you've ever tried to get any significant health services for a chronic condition, you know how tough it can be to work in our healthcare system. He also found that we don't do a very good job in the healthcare world about educating patients about healthy behavior, about their diseases. Health literacy wasn't very good for the population, our population in the United States. A lot of people don't know their history of medical illnesses in their family. We're not very good at looking at how to change health behavior. We really are pill-based and just kind of want a solution pretty quickly for these things. So he found the health system didn't do a good job of helping us manage our self-support as patients. And then he saw that the community wasn't really linked in with the health system. We have things like the YMCA and Parks and Recreation weren't working closely with, even public health wasn't doing as good a job linking with providers like yourselves or primary care and specialty care services, and that there could be a better approach to doing that. He said if we can deal with these things and clean them up, what we'll end up with is informed, activated patients. Activated meaning the patient can actually make decisions about their health and improve their health through decisions they make throughout their day, in their lives. So they'll be better informed, activated. We'll have team-based approaches that are prepared and proactive, both proactive working with the community and proactive working with the patients. And then we would end up with functional outcomes. So out of that came this idea that's an old one, this patient-centered medical home. Have we heard about this? This actually came out of pediatrics in the 60s. They were doing this back then. It's kind of common sense if you think through things. But if you look at the current system we have in place, making our system line up with these principles is going to be a bit of work, because a lot of what they're talking about here is Wagner's model and is luckily for you all, what you already do to an extent. So as substance abuse providers, as behavioral health providers, you're in pretty good shape for developing patient-centered medical homes because you do a lot of this already. You do a lot of work with patients around health behavior change because that's what you're in the business of doing. So you're constantly talking to them about how to change their behavior. You might not have an ongoing relationship with the physicians that these folks you're serving work with, their primary care doc, but we'll talk about that because that needs to be improved a bit. You definitely have a whole person orientation. You have a team-based approach most of the time. Acute, chronic, and preventative. You guys do that, right? Pretty much? Heads are nodding, thank you. Span of life care. Maybe we could do a little bit better of early identification for substance use disorders and mental illness. A lot of research showing that if you can get a kids, 7, 8 years old, and start looking at whether they're going to develop a serious chronic mental illness, or 8 years old being the average start of substance use by many, you can start to have a better impact. So we could probably do a little bit better there, but we do pretty well. We work with families and communities pretty well. I think you guys are pretty tuned into who's going to be able to help pay for heat, and if you can get a YMCA pass as a consumer of your services, pretty tied in there, so we do that pretty well. Quality, safety hallmarks are pretty much there. Are most of you CARF certified? CARF, JCO, state?
Yes.
State, okay. So there's some quality issues maybe that will need some improving. We'll talk about that, how the healthcare system does that, the physical health. Access to care, we could probably do a little bit better job there. Open access, there's big movement towards having clinics open on weekends, evenings, having clinics in things like malls, Walmarts, so that people can actually engage in treatment in the regular routine of their day. So if they're going to Costco, why not have the ability to go in and get some primary care or even behavioral health services too, or check in and get some prevention done. Payment is going to be recognizing added value. We don't do a very good job with that, I don't think, in behavioral health, where we oftentimes don't have metrics tied to outcomes related to costs. So we can't say, hey, it costs this much to treat this person to get them to this level. It's because it's really hard to do, frankly, but it's also because that hasn't been something we've had to focus on because of the way the funding systems are set up. And then being able to provide personal physician approach. The patient-centered medical home concept is that anyone, including you, will have one primary doctor or nurse practitioner or PA that you see as being the person you trust and go to get all your healthcare needs. That person will be a central point. It will probably be a primary care provider, an internist, or pediatrician, but there is a lot of talk around psychiatry being able to do that, especially if you're someone that primarily sees your psychiatrist. Could they screen for some primary care issues and get you to the right doctors so that you can get the care you need? So there's a lot of talk now about whether psychiatry could play that role or not, but it makes sense for the folks that are comfortable coming to see you all in psychiatry, then they are going to see a primary care doc that they might not have much of a relationship with. Any questions on person-centered medical homes?
Well, I'm watching that model.
Yeah.
It's similar to wraparound services that started in 1989, the real wraparound services.
Yes.
And there was plenty of money at that time. So that way in 1989, when that healthcare reform started up something new again, they had the wraparound model and money was plentiful. And then that way families and children and providers, people were well taken care of.
Get screening and everything back then.
Excuse me?
You get screening and everything done back
Yeah,
then.
yeah, we had plenty of money, but we're going back again. It's like a cycle. We're going back again to the wraparound process.
So your point is that this is a cycle we seem to go through as human beings. It's like a pendulum. It goes back. The system, yeah.
The system.
And that we had this kind of services through wraparound in 1989, where there was more funding.
And hopefully, though, the money will be replenished again like it was back in 1989. 1989.
Plan on the money being
Yeah, right. That's what we need. Yeah, that's what we need, the money again.
Yeah, well, however, I think in 1989, as a field, we could have done a better job in linking cost to the services, which might have helped us make a better case for keeping that money on the table, but I don't know. But your point is well taken. As we move forward, you'll also hear a little different spin on patient-centered medical homes, this idea of a health home. Have people heard this? This is coming out of Affordable Care Act language. It's the state plan amendments that allow states to access health home funding that would allow states to set up health homes for people with behavioral health conditions. So it's specific monies to help states get better organized when it comes to integrating primary care and behavioral health. Some states have really run out of the gate and grabbed that money. States like Ohio, California has done a bit of work, Missouri. Baltimore, I was checking with some of the folks here and they weren't clear as to whether Baltimore had applied for those funds or not, but they're still available. So if you hear health homes, that's what that is.
Well, nursing homes are utilizing a lot of health home care.
Yeah.
People who live in nursing homes and rehab centers.
Yes, nursing homes, and they're the first ones to start working with these accountable care organizations through Medicare. They're piloting a lot of this accountable care work through Medicare, so they're getting a lot of the long-term care services are starting to get tied into this now. You're right. Have people heard of NCQA? Yes? Some? This is a body much like JACO or CARF that is out there, has primarily worked with hospital systems, and they are very metrics based. So when they come to your facility to do a review, they don't ask for a chart and do a tracer, or kind of make sure your notes line up with, your goals and your treatment plan. They want to know, the specific code you use to calculate outcomes. They want to see the computer code. They want to know specifically what the numbers were of the number of people you served and how many got better or didn't. So they're very, very metric focused. And they were the first out of the gate with health reform to start designing the criteria for these patient-centered medical homes. And right now, if you go on the web and take a look at medical homes and what the criteria are to be certified as a medical home, it's quite, it's loose. There's not a lot of metrics there because they're developing the concepts. But in time, the NCQA is really going to be the place that is going to certify whether your medical home is doing the right thing or not, and whether you get paid or not. So it's a very important organization to be watching because they're doing a lot of work with the feds, and they are very much metrics based, which again, as I mentioned before, our field hasn't traditionally been. So it's something to keep an eye out for. Check out the current criteria they have for medical homes. It's good stuff. It's definitely good stuff. And I should mention this final bullet here. If you're wondering if this is going to have a big impact on your job, just looking at the numbers says a lot. About $23 billion in Affordable Care Act monies went to HRSA, the Health Services Resource Administration. That's like SAMHSA is for primary care. They support all primary care and federally qualified health centers. SAMHSA got about $54 million. So it kind of, you read the writing on the wall, the money's going to primary care to develop these health homes. The system is really putting their best bets on patient-centered medical homes and primary care as the place to reform and help our system. So we need to be on board with primary care and getting to know primary care better and letting them know that, hey, we've got a lot of the things covered that are requirements of these patient-centered medical homes. We do this stuff really well, and start really making sure that we show some leadership and take some credit for the good work that you guys do, because we do this stuff that they're asking to be done with all patients.
And they also do it in nursing homes as well.
Yeah, nursing homes do a pretty good job of this also.
Yeah.
So this integrated care, just for the visual people like me, this slide kind of brings it back home, and we can go back as far as blaming on Rene Descartes, I think therefore I am kind of stuff with the whole separation of mind and body. But integration really is about connecting the head back to the body and getting physical health and behavioral health back together in a holistic approach to recovery, which is really you know, it should be obvious that we don't do it that way, but we do it that way. We've even separated out substance abuse and mental illness. So, you know, we're getting better, we're learning, and hopefully it won't be, you know, cyclical and we'll go back to the bad ways of before. But I want to talk now just a little bit about health conditions, physical health conditions in the population of people that you work with. There were some reports out by C.J. Peak and, you know, Joe Parks, and people have done some really great stuff showing that people with substance abuse and mental illnesses die younger than the general population. This is something we've known for a very, very long time. This isn't a shock. If you've been a case manager or worked in this field, you've seen people die young. And this was going on back in the 30s. So the fact that we're now paying attention to it has a lot more to say about the fact we're running out of money in our healthcare system than it does that we've kind of, you know, suddenly realized this. But they knew this back in the 30s. People were dying of cardiac disease at a younger age. Tuberculosis we have much better control on now, but artery disease, peripheral artery disease, people are dying of. And a lot of the ways we couch it is that, I know in the agency I worked at, we wanted to know, is this really true? We served, you know, thousands of people with, we were both a licensed substance abuse provider and mental health agency. Are our caseloads dying younger? And we found out that they were. They were dying at an average age of 53 years old. And when we looked at the autopsy reports, if there were any, or the death notices, the death certificates, it said natural causes. They died of natural causes. So there's nothing natural about dying that young. So as a system, we've just kind of not paid as much attention to it as we should. NASHBID did a very nice study and great PowerPoints if you go online to see some of the research they did in looking at this. But they found that, again, people were dying at a much younger age, and people with co-occurring mental health and substance abuse die even younger. They're even worse off. They're dying at 45. And they're dying from preventable preventable physical illnesses. If you look at the lifespan around the world, where in the world do people die at the age of 53? It's in sub-Saharan Africa, which is basically war-torn, and the AIDS virus has really just raked those populations. And that's the same lifespan that we have people in the U.S. with these conditions achieving in their lives. They're dying young. It's just not acceptable. And they're dying from the things we know, and this isn't going to be shocking to you all. They're dying because of smoking, alcohol consumption, lack of movement. They're victimized, they're unemployed, there's a lot of stress in their life, which we know isn't good for health. They have lots and lots of chronic stress. It ruins your cardiovascular system to have that much, those types of hormones coursing through your veins all day long as you're stressed out. We know that poverty is really a form of violence. It is quite devastating to people. So we know the preventable causes, we know they're there. I think what we could do is a better job of screening for some of this stuff. And again, I don't think the message to you all as a group is, hey, now you're going to become primary care providers and let's have you start screening for every physical illness because we want to just add that to your plate of fun things you do all day. I think the idea is let's leverage what you already do well, which is health behavior change. And let's just add some screening tools, particularly with the nurses you work with. Hopefully you've got nurses working in your clinics. So you can start to just get a better lay of the land around physical health conditions that the folks that are showing up in your offices have, so that you can start better linking with primary care. So we could do better with chronic disease management. We could start using our health behavior change skills to not just talk about substance use, but maybe talk about eating and exercise and changing behavior around that. And then using those relationships we have and our relationship building skills to work with primary care. Because primary care is a tough nut to crack in many ways, to get relationships with primary care offices and clinicians, because they've got busy lives too. They're in their silo, we're in our silo. So it takes somebody being willing to climb out and knock on the other one and start a relationship. So it really takes that relationship to be built. And if you don't want to do it for all the right reasons related to that, then we really need to do it and get people used to talking with managed care organizations. because if we're not at the table with health reform, we'll be under the table or on top of the table being eaten. So we got to be careful when it comes to health reform and make sure, especially you administrators in the room, make sure you're developing relationships across health providers in your communities.
You know what?
Yes?
We can do all that, but to me, I know in mental health, and at one point when I was working in the mental health field, a patient had, say if they were at a program, they had a counselor, and then they also had a case manager. But in the substance abuse field, they have kind of taken that case management role and kind of put it on the counselor. So the counselor is having to do case management. Case management is linking them to the various services that the patient need, but then they also have to do counseling. So it's kind of hard. It's like maybe specifically substance abuse, if they could still bring that case management. And the reason why case management were kind of taken out because of the funding. They couldn't support that a position. They're asking providers to maybe have case management, but they can't really afford that, to have a case manager. And I think that's a major problem too, especially in the substance abuse field. They don't have that case management to link the folks. You can have all these providers that provide health care, different, even down to the gums. I was working with a patient who ended up passing away because over the years she was mentally ill, but she didn't realize she needed to go to the dentist.
And a lot of times dental isn't covered.
So it's little things like that our patients experience that they don't know. They haven't been out there. They don't know about these things. But I notice that's a key factor, is to try to keep case management in, but it has been cut out.
Yeah, and the comment is that, especially in the substance abuse arena, case management's been cut out, so it's outpatient therapists then needing to do both therapy, but also case management, which is really hard to do.
It's hard to do.
And you're absolutely correct. And one of the potential solutions that there's a lot of push for now is the use of peers more. So using more sponsors. In the primary care world, they call them community health workers. In the mental health world, they call them peers, and substance abuse is often sponsors or coaches. But finding ways to pay people to do that kind of work, which could get at some of the case management. So there's movement now to use skilled folks so they get some training around basic coordination of care, basic health condition screening, so that they can become paid to work with you all. So that's one approach, but you're absolutely correct. It's a real problem that you all as outpatient therapists now have to do the case management piece. But a lot of what you do is education. So whether you're doing therapy or not, it's kind of the same thing when it comes to education and helping the person realize that they, in order to change their behavior, they need more information and they need to act on that information. So things around, how to better coordinate and work with primary care is something that I think a therapist could do. But if the person's really there to deal with a specific trauma issue, it's going to get in the way, or a specific substance abuse issue. It's going to make that care you're going to need to provide last longer. There's no doubt about it. A good point. Any other comments?
Yeah, that's one of the things you talk about when you talk about a holistic approach.
Yeah.
As far as I know, substance abuse has been, or supposed to be anyway, looking at a holistic approach: the emotional, physical, spiritual, mental cycle of the whole being.
Yes.
And if you look at that approach of the whole being, then all that will be involved. And like you said, having skilled workers who know the training and being educated about the holistic approach. Because if I'm feeling good physically and I'm feeling good spiritually and mentally, then my mind and heart behavior will change, and I won't want to use drugs if I'm getting the right kind of treatment at a holistic approach. And I've been in the field since '86, and I have always taught holistic, even when they weren't even talking about mental health.
Yeah.
And it's how can you treat one part and not the other?
Yeah.
It's true.
And I think your point's well taken about this. In our field, we do take a holistic approach to providing care, which is not common across all health disciplines, certainly. So it's leveraging that, and it's reminding ourselves of that, and maybe beefing up a little bit more of the physical health piece of that than we have before. And we're going to talk a little bit more about how that looks.
Aaron,
Yes?
you know, and I just wanted to say too, and I do agree with what she said, but for women in substance abuse, women have gender-specific needs that are not being addressed in some areas, specifically in the Baltimore County Detention Center. The needs are just not being met. There's a trauma, domestic violence, all kinds of other issues that play a part as to why women can't stay clean. Or
Yeah,
they do
and-
not stay in treatment. They have kids. You know, one of the biggest reasons, when I talk to women, one of the biggest reasons that they don't stay in treatment is because of their children. So there are gender-specific needs that should be addressed as well.
Yeah, there are definitely gender-specific needs. The comment is especially for women who are in the justice system, you know, there's some very specific needs that aren't being met, which gets in the way of them being able to kind of, for themselves, being able to take a whole health approach to changing their lives, because there's just big gaps in the care. So this is not easy stuff, and this is stuff that's not going to get easy because of health reform. But you guys are doing it, and if we can tweak it a little bit, get a little more information, it will be helpful in our practices,
Well, we
hopefully.
need the officers, and for those incarcerated, we need the officers here for training. Because
Yeah, that's a good-
It's the criminal justice system versus.
Getting the criminal justice
Yeah,
system more training around whole health.
dealing with a person who's ill. And so one of our biggest barriers in that incarceration arena is the custody, you know, and we deal with that every day. And it's very difficult when you're talking about service reform, system reform. We really have to bring other areas into training and educating. In the criminal system, they're on their way, but I mean the frontline workers,
Yeah.
like the officers, okay, the
Yes.
judges and the lawyers, and you know, they're
Now-
coming on board, but we
now
need
is
officers in here.
The time to do that. The
Yeah.
comment is we really need to get more involvement by things like officers and folks that are working in jails, to get them educated about what it takes for people to get better. And now is really the time to do that, if we're going to do it at all, because today with health reform, we haven't seen changes like this since probably the 60s, you know, when Medicare, Medicaid were making some major advances. So it's almost like right now we're in this big vat of jello that hasn't solidified yet. So things can move around. We can start to, you know, have access to conversations that we weren't able to have before. But eventually it's going to solidify, and people in systems will be in the place they're in because the funding will be set up in a certain way. So having those conversations is really, really important with different systems, so that they can start to, when people are in a mode of change, that's, as you guys know, that's when to start bringing up creative ideas, because they'll be willing to hear it. Some of the health indicators that are being suggested that mental health and substance abuse providers collect are these. And these, again, are probably things that are going to come along with NCQA-like criteria for substance abuse and mental health. And they're things that a lot of places are already providing, are already screening for, that psychiatry and nursing can do. But basically a personal history of your, you know, whether they have diabetes, this is hypertension, cardiovascular disease, family history, weight, body mass, waist circumference is another one that's really good. It's a nice complement to body mass index, which I'll talk about. Blood pressure, glucose, HbA1c, which I'm going to talk more about, which is another way of measuring blood sugar. Lipid profile, tobacco use, substance use, medication history. These are all things that we're really going to be required to collect. And a lot of places are already doing this. I don't know if you all are, but a lot of places have already picked this up as things to collect. Yes?
I know the majority of those things that you just had listed up there, and doing a thorough intake assessment, along with doing a biopsychosocial, a lot of those questions are already being asked, or a lot of those issues are already being addressed.
Perfect.
You have to get the family history, but what I find is that a lot of times, tobacco usage and cigarette smokes, you know, it's not that question, when I ask it, And then the answer that comes back to me is that no one has ever asked them that before.
Really?
At what age did you start smoking? How long have you been smoking? Is there a family history of it? And when you're doing substance abuse, a lot of times tobacco is not even mentioned. Nicotine is not even mentioned, inclusive of the drugs. You know, even though, right, no, I'm just saying, but like I'm saying, the feedback that I get
You
from
don't
the
dig
people that's
into it.
coming in, the
Yeah.
feedback that I get, you know, people who've been through different treatment programs, and then the feedback that I get back from them is that no one has ever asked me that before, because sometimes there's no correlation between
Well-
the tobacco and the other drugs, and we know there's a direct connection.
Yeah, we do. The
Right.
comment is that, you know, we could do a better job of screening for tobacco and
Right.
engaging people around their tobacco use. And there are many reasons why we don't engage them as much, I think, but it's important to know that 2/3 of the people that smoke cigarettes in this country are the people you serve. Another 20% are you all. Health providers smoke a lot.
Well, in the state of Maryland now, they're required to even include that as part of the treatment plan once they do the assessment.
They are required to
They're
include
required to
substance.
make sure that that is part of the treatment plan.
Okay, good.
It's-
Yeah, and I think a lot of times we don't engage it because there's bigger fish to fry.
Yeah.
And I think there's a culture, I mean, I remember when I was doing case management, we used cigarettes in very creative ways to get people to do stuff. So there's a little bit of that left in our thinking. I don't think we do that anymore, I hope, but we could do better. We could do better. So these are the health indicators we're going to see being required moving forward. For you all, the big issue is going to be not so much, skills around health behavior change. There'll be some tweaking there around how to include physical health issues into the work you do. But it's really going to be around how do you engage primary care? How do you, reach out to them and have them reach back or at least listen to you so you can help better coordinate the care? Because the reason why people are dying young is because they're not getting access to primary care. Because they just don't think about it, like the lady who talked about with the person who had dental issues, it just really wasn't motivated to get to the dentist or thought through it enough to get there. But also because the primary care field and a lot of specialty health providers just have a hard time serving the folks we serve for a variety of reasons. So we can help them with that. And I think that's the primary job. If things are going to be added to your plate, that you guys are going to have added to your plate. And there's a lot of different ways to do that. Certainly this training might be one little movement in that direction. So it's good to understand the two worlds of primary care and behavioral health so that you can get inside the minds of primary care providers because they think differently than you think. Before I got into behavioral health, I was a paramedic. Got into behavioral health through doing critical incident stress debriefing that was big in the early 90s, late 80s. But I can tell you, primary care providers think very differently than we do. They have a very, very problem-focused approach to things. They're not so much biopsychosocial, spiritual assessment type people. They are looking for a specific problem and a specific solution and then moving people along. And if you've been to your primary care doc, you see this. I mean, they're nice people. They're wonderful people doing great work. It's just they are captured in a system that's very different than ours, primarily because of the way things are built. So they're very problem focused, and they're going to talk about getting a list of problems and then trying to find a solution to one of them, the biggest problem, and then moving the person along. They want immediate solutions. Their productivity is measured in numbers of people seen. So I often think of it like going to the mechanic. If you're a mechanic, there's a book that basically says replacing a transmission should take this long and cost this much. And if you're a really good mechanic, you can replace 2 transmissions in the time it takes, based on the book, to replace 1. So what does that mean? You get paid twice for the same amount of time. That's how primary care is funded. So the more patients they see, they just get a nice fee for everybody they see. So if they add more people to the hour, they get paid more. Whereas the way we're set up, we're based on units of service, 15-minute intervals, typically something along those lines. So it's much more spread out. Our thinking is completely different than their thinking. And it's not that the primary care docs are saying, hey, I want to make money. Like the money's going right into their pockets. There are some practice-based physician groups where some of, it gets to that. But most of them are driven by, you know, healthcare organizations saying, you got to reach this much productivity. Just like you all probably have a 60-40 face-to-face billable or something along those lines, 70-30. They have the same thing. Their caseloads are usually about 1,200 patients for one primary care doc, maybe 800 to 900 patients if you're a nurse practitioner or a PA. So they have a lot of people they're seeing. So they're pretty busy, much like you. Many evidence-based interventions, because they are so problem-focused and so efficient in moving people through, identifying problems and solving them, they work from the standpoint of flowcharts and evidence-based practice. So there are decisions they make as they unpack a problem that have lots of evidence to them. So for them, if you come in with a specific condition, there's usually a recipe that they can go look to or that they've internalized because they know it because they've done it so many times that leads to a solution. With us, I mean, we get what shows up at that moment, and it's usually emotion-based, and it's usually crisis-based based on what that person's experiencing in their life. And there's really no flowchart or evidence-based practice for that. So it leads us to have to see people for longer periods of time and see them longer, that sort of thing. So they really, the primary care world doesn't understand that. And if you talk to the primary care folks, and surveys have been done, when you ask them about substance abuse providers and mental health providers, and say, hey, you know, we need to better coordinate. What do you know, how do you think we could do that? They say, behavioral health and substance abuse, it's too hard for us to get our patients into those services. And we reach out to them, and they just basically tell us the person isn't appropriate for their services. Because the way our services are set up, you've got to be pretty darn sick to get into them. For mental illness, you've got to have had several hospitalizations and pretty much brain damage from psychosis to get into a community mental health center. Substance abuse providers, same way. I mean, you got to be pretty motivated to get into substance abuse. And primary care docs don't have the support staff or the time to really do that kind of linkaging and case management piece. So this divide is pretty significant as far as different mental models that clinicians use when they go in and do their work every day. So bridging that gap is going to take some work, and luckily, you know, you're all in the process world. You're more in the, you know, relationship building world than primary care probably is. So it's going to be important that, oops, I went in the wrong direction, sorry guys. It's going to be important that you all use the skills that you have so that you can create relationships with these primary care docs. Because it's going to be difficult for them to reach out to you. And a lot of them obviously aren't doing it because our folks aren't getting really great access to care at this time because of some of the barriers that exist within their systems. So, and just to highlight this a little bit more, when primary care docs look at this list of, you know, issues for the person, this is how they unpack it. Diabetes is the biggest concern in this list because it affects all the body systems. Schizophrenia and alcohol are down here because they assume you guys are going to take care of that. We kind of do the same thing. So where does that leave the consumer of services? They're kind of in the middle as far as making sure that these two sides are talking to one another and have that kind of information. So in order to bridge that divide, there's some things you guys can do. There's things that your administrators can do, your leadership in your organizations, and it's really focused around putting together a very simple elevator speech around what your agency or what you as a clinician, if you're talking directly with a nurse or a primary care provider, can do for them and what you do for consumers. Because a lot of times they don't know. Yes?
Yeah, I think in order for this to work, the physicians need to be mandated to go to like substance abuse training before they can get their certificate. I've had some patients who do not want their primary care doctor to know that they're on methadone. Because once they know, they are being treated differently, like they are nobody. So in order for this to work, the physicians and the nurses, they really need to take a training in substance abuse.
I agree. The comment is that it would be very helpful if physicians and nurses and primary care staff had more training in substance abuse and mental illness. And you're absolutely right. I know when I manage a couple integrated health clinics, and the first one we got going, it was really hard to get it going because the staff were really resistant to seeing people who had substance use disorders and who were actively psychotic. And we talked to the physicians, we talked to the nurses, we gave them education around that, and there were still issues with it. And what we found out was the front desk staff, we hadn't trained them, and they were really running the clinic as far as being concerned that they didn't want these people in the waiting room. So as soon as we did some training with them, they felt more comfortable engaging. They had some tools to engage these folks, and it really worked a lot better. So it's going to take time, and you're exactly right. It's going to take training, and a lot of systems, you kind of go where you can as far as building a relationship, right? If you're dating somebody or just want to get to know somebody, you kind of strike up a conversation around what they're interested in. So a lot of times these conversations we're having with primary care, and of course we've got to have them if we need consent to be able to do that, especially around substance abuse. A little less so in mental health, but we can talk about HIPAA if people are interested in that. But a lot of the approaches that we're going to need to take to the primary care folks that are going to be impactful to them are conversations that really meet or really address the needs that they have. And their primary need that they're telling us is more access and help with getting people into your services or knowing who is in your services. So that's one place you can start. But whatever you can do to kind of develop the relationships with the office staff, with the nurses, with the primary care docs, bring business cards, go on a couple appointments if you know there's a physician group or a federally qualified health center that sees a lot of the folks you see. Go on a couple visits, carve out some time, go to the primary care appointments with your consumers if your consumers are okay with that. Introduce yourself, let them know what you're able to do, what you can't do, what you would love that they did, and really work through the consumer to be able to get access to these staff, because it's going to be really important that you guys develop relationships. Because the concern is, if we don't as a system, that these accountable care organizations are going to just assume you guys don't exist and pick other people to provide the care that you're providing. We've already seen it with Medicare ACOs that are being developed. The accountable care organizations, these hospital systems that got the green light to be an accountable care organization, had to pick behavioral health panels, in order to, through their application as an accountable care organization. And most of them did not pick the primary substance abuse providers in their communities or mental health centers. They picked their own clinicians that work in outpatient in all their health centers around their hospital system. So part of the reason is they don't know you guys exist, or they don't think that you guys are approachable, or it doesn't make sense for them to think about you all. So it's important that you guys are doing a little bit of promoting of yourselves. Yes?
Well, along those lines, it may not just so much be us. I mean, it's 2013, 12, maybe 13, and most of the clients that we work with still suffer from, if not a double, a triple stigma, and that's associated with the concerns that they had, and so here we are, we're talking about healthcare reform, as well we should be, and like you just said, we still have to kind of force our way into saying that this is just a viable chronic disease as this one is. A lot of times the comparison is made, say, between diabetes and a substance abuse problem. Should one go untreated and the other one not? Well, that's a comparison. I mean, health concern. I mean, it's a health concern. We're still here. We still struggle with the stigma of substance abuse, mental health, incarceration, HIV. I mean, in our community at large, and so we're struggling with that. So, can you speak to in health reform? Is there any type of maybe social marketing efforts? I mean, to elevate the status of the behavioral health concerns.
Very good point. So the point is, a lot of the folks we work with have the triple stigma issue. We get caught up in that, and why is it on our backs to be the ones that have to, really reach out and get primary care to start thinking differently? I think part of that is we just have to do it because of the stigma that's out there. We're just stuck with this situation, and it's not a good one. However, there is a lot of work going on now and a lot of research to show that if these accountable care organizations are going to work and be cost neutral at least, that the primary care field needs to do better around helping people with health behavior change, whether it's for mental illness or losing weight or anything like that. And they're going to have to do that. So it's a lot of work and money going through HRSA to train mostly federally qualified health centers to start. Because federally qualified, do people know what federally qualified health center is? It's kind of like the substance abuse community mental health equivalent of primary care, where they serve a lot of low-income folks. And families. They're doing a lot of training with them around substance abuse, mental health, and motivational interviewing techniques, and really encouraging them to hire behavioral health and substance abuse specialists to put them in the clinics. And I don't know if you guys hear about bi-directional integration or even integrated health. That's a lot of the models that are being developed where you get substance abuse providers actually in the primary care clinics working in the offices. And I don't know if anybody's doing that here, but that's really a big push to get at your point so you're not left holding the bag. But again, whether we like it or not, this is the situation we're in. Primary care has a much louder voice and a lot more money than we do. So we need to step up. Yes?
Although I agree with everything you're saying, I do want to piggyback on what he said. We've been around for a long time, and even physicians in the field do not even buy the concept model of addiction as a disease. There are some people that are actually treating SUDs and not looking at it as a disease model. And I can't even remember who commented about the jail piece, but the country on a whole treats addiction as a criminal offense. So then you're asking us to, to go in and to challenge what people pretty much believe is a criminal offense and not a disease model. So I mean, I think it's going to be really, really difficult. So it isn't that we're not trying to get at the table. It really is that the table doesn't even understand what addiction is.
So the comment is, we're really, as clinicians and it's a field, in a tough position because a lot of physicians don't even adopt the disease model for addiction. And we've been driving that for many years now. The 90s was a decade of the brain, if I remember. So you're right, it's an uphill battle, but it's one that, given the shift in funding, that we need to keep waging. And it's getting a little better as far as organizations like HRSA and medical training shifting towards looking at what integration means and what behavioral health is and how we can train primary care docs. So there is a generation of doctors, I think, that are going to be coming up that are more open to this. We need a bunch to retire, frankly. But, it's a process. But I feel your pain. You're absolutely right. You're absolutely right. I want to be conscious of the time. So we want to break at 10:15, did we say, or 10:30? 10:15. So we've got 3 more minutes. All right, I'm going to talk for 3 more minutes. There's a handout that you've got. There's just some recommendations. It's the one-pager. Some recommendations around how to engage consumers and folks at the primary care visit around your role and how to support them through that. A lot of this stuff I think you guys already know around helping people engage primary care if they're willing to have that conversation with you even to begin with. But a lot of what we're hearing from consumers is the big barriers are that the visits are too quick. I forget what I was going to ask, and the waiting room is too difficult to navigate because I need to smoke or, it's just too weird going to their appointment. I'm more comfortable coming to see you all. So those those three big issues are things that you can strike up a conversation with folks about if you know they have a primary care doc, to begin the conversation around, hey, you know, when was the last time you saw them, and how can we get you in there to at least get some screening done or just a check-in, if they're willing to do that with you. And again, it only takes one or two people on your caseloads to kind of spark a conversation that's going to allow you to get in the door of a primary care visit and actually have a conversation with a doctor. Also talking with your quality improvement or your administrative staff around, hey, we need a report that shows all the primary care docs on all the caseloads so that we know that, if you can, and whether we have consents to talk with those primary care docs. And then a report to show who are most of the people that we serve as an agency going to see. Are they going to the FQAC down the street, or are they going to this nice doctor who just seems to really work with our folks well and are seeing a lot of our people, so we want to reach out to that doctor. So really kind of having a strategic approach and having administration help with that can be really valuable to kind of move the conversation along and move the process along. So why don't we take a break here at 10:15. Can you guys be back in 10 minutes?